This first test is called the valgus stress test, which is assessing the integrity of the medial collateral ligament. So I'll first palpate that medial joint line space, and I'll apply a valgus force with the patient's knee fully extended. And I can also do this with the patient's knee in 30 degrees of flexion, still applying that valgus force when I palpate the medial joint line there. And a positive response would be reproduction of the patient's pain or excessive gapping noted. This is called the varus stress test, so it's going to be assessing the integrity of the LCL ligament. As I palpate for the lateral joint line, I'm going to apply a varus force, and the knee isn't fully extended here, but I can also do this with the knee at 30 degrees of flexion, applying that varus force, and a positive response would be a reproduction of the patient's complaints of pain or excessive gapping noted. This next test is called the Houston's valgus test, so it's a variation of the valgus test. The main difference here is I'm going to use the table to stabilize the patient's thigh more, and I grab at the first ray and big toe, and I still apply that valgus force with the patient's knee fully extended, and I can also flex his knee again to 30 degrees and apply that same valgus force. And this test is assessing for one plane medial instability, and a positive test would be a painful reproduction of his symptoms. This is called the Houston's varus test, which is another modification of the varus stress test. So I'm going to use the table to stabilize the patient's thigh. I'm grabbing at the 4th and 5th digits this time and applying a varus force. And a positive test here would be a reproduction of the patient's pain, indicating a problem at the LCL or lateral structures. And I can also do this with the knee 30 degrees flexed. And I'm going to again apply that varus force, looking for a reproduction of the patient's painful symptoms. This next test is called the anterior drawer test, assessing for an ACL injury. So what I'm going to do is I'm going to flex the patient's knee to 90 degrees and the hip to 45 degrees. I'm going to sit on his foot for better stability, and I'm going to palpate that joint line space, and I'm going to pull in an anterior direction, and a positive response would be a painful reproduction of his symptoms. This next test is called the posterior drawer test, assessing for a PCL injury, again palpating that joint line space and now pushing in a posterior direction, and a positive test response would be a painful reproduction of symptoms. This next test is called the Lockman test, which is a gold standard test for assessing anterior instability, specifically ACL injuries. So I'm going to flex the patient's knee onto my thigh, and I'm going to use one hand to support the distal femur, and the other hand is going to provide that anterior drawer test. So a positive response will be a reproduction of the patient's pain, indicating a potential ACL injury. This next test is called the Godfrey test to assess for posterior instability. So I'm going to bend the hip and knee to 90-90 and look at the tibia and look if there is a sag there as compared to the patella. So if there is, this would be a positive test indicating some posterior instability, but here this patient is fine. But as always, compare this finding to the uninvolved side. This next test is called the posterior sag sign, which is another test for assessing posterior instability or a PCL injury. So I'm going to flex the patient's knee to 90 degrees, and a positive finding would be the tibia dropping back or sagging posteriorly on the femur if there is a torn PCL. So the Slocum test is performed for suspected multidirectional instability. So I'll combine motions with the drawer test, first by internally rotating the tibia and foot to 30 degrees, and then I'll do that anterior drawer test here. So if pain is reproduced here or I notice laxity, that's a positive response for the lateral structures. But I can also do this with the foot in 15 degrees of external rotation and externally rotating the tibia, and again providing that anterior drawer. And if I reproduce the patient's pain or laxity, that would be a positive response. This next test is called the Thessaly test, which assesses for meniscal involvement. So I'm going to have the patient stand on one leg and flex his knee to about 20 degrees. And then I'm going to have him grab onto my arms, and we're going to twist his hips and knee while standing on that one leg in place, following me. So this is basically causing a twist over the meniscus while we move to the opposite direction, and a positive test would be a clicking, popping, or a reproduction of his complaints. This next test is called the McMurray test, which is done if there's suspected meniscal lesions at the knee. So first I'm going to be testing for a medial meniscal problem, so I'll palpate the medial joint line and I'll externally rotate the tibia and extend the knee for medial meniscus, and a positive test would be a pop, click, or reproducing the patient's pain. I can also do this to assess for a lateral meniscus lesion, so I will palpate the lateral joint line space, and then I will internally rotate the tibia as I extend the knee, again looking for a reproduction of the patient's complaints or a popping or clicking noise. This next test is the Apley test for suspected meniscal lesions. With the patient in prone, I apply a compression force of the calcaneus, grinding on the meniscus by internally and externally rotating the foot, and a positive response there would be a reproduction of the patient's complaints of pain. I can also do a distraction technique here, so I will stabilize the distal femur and distract there while internally and externally rotating the foot again, and a positive response here would be reproduction of his complaints of pain, which may indicate rather a ligamentous issue. This next test is called the Agues test, which is done to assess for meniscal lesions. So when checking the medial meniscus, I'll have the patient maximally externally rotate his feet and squat down. A positive response for both tests will be equal reproduction of pain at the joint line. So for the next part of the test, I'll have the patient maximally internally rotate his feet and then squat down, which assesses the lateral meniscus. This next test is called the brush stroke test for assessing knee effusion. So first I'll brush superiorly on the medial side of the patient's knee a few times, and then after that I will come down laterally and brush on that lateral side of the knee, looking for a bubble of effusion to form in the joint capsule. So then I begin pressing laterally, brushing down. So effusion is graded by when it appears. A 1+ would be a small bubble, a 2+ is a bigger area of effusion noted, a 3+ would be excessive effusion just by completing those superior strokes, and a 4+ is excessive effusion and not even able to do any strokes. This next test is called the patellar tap test, so I'm going to start by brushing down to stabilize that patella superiorly. Then I will come up and use my fingers to tap right on the patella, and a positive test would be increased patella motion or a spongy joint feeling. This next test is called Clark's patellar grind test for assessing patellofemoral issues. So I'm going to compress down onto the patient's patella and have him tighten his thigh like he's doing a quad set. A positive test here will be excessive crepitus or reproducing his complaints of pain. I can also do this test with the patient sitting down. So I'm going to rest my hand over his patella and have him extend his knee while I feel for crepitus. Then I can give more of a compression force on that patella and see if this is sore as well. This next test is called the McConnell test, used for assessing patellofemoral dysfunction. It's done in various points of knee flexion. So first we're going to start back at 120 degrees of knee flexion and give a resisted isometric quad contraction. Then we'll move into 90 degrees and then 60 following the 90, and then again I'm looking for pain at a certain position, and then we'll go to 30 degrees and lastly assessing this at full extension. So then I'm going to go back to the painful degree. Let's say it was at 90 degrees. I'm going to use my hand to push medially to reposition the patella, have the patient resist me, and if this is less painful, then that's a positive test result. This next test is called the Noble compression test, done if there's a patient complaining of lateral knee pain. So I'm going to use my thumb and web space to find the lateral femoral condyle, come just off of it, and I'm going to give compression, passively bringing the knee into extension. If the patient has pain about 30 degrees from full extension, that's a positive response as we stretch the IT band right across that area. So this is the pivot shift test. I'll start with the patient's leg fully extended. My hand's going to be palpating over the proximal side of the lateral tibia. I'll bend the knee down into internal rotation and flexion, and a positive response will be reproducing the patient's complaints or subluxation of the tibia while the femur rotates externally. This next test is called the reverse pivot shift test to assess for posterior lateral rotary instability. I'll start with the patient's knee flexed at 90 degrees, and I'll bring the tibia into external rotation and while I'm extending the knee. And a positive response will be subluxation with or without a click, or possibly reproducing the patient's symptoms.